My name is Priya, and this is a very big topic, and I'll try to give you some examples and run through some of the important AI applications in this area. These are my disclosures. And so there are two types, actually, virtual AI and physical AI. The virtual AI is applying this technology into existing data sets, imaging, slides, and etc. The physical AI is, of course, as Dr. Alba discussed, using robotics machines and using those in a certain way to do surgeries and various other things. So the benefits include precision diagnosis, individualized therapies, improved patient outcomes, and of course the cost savings. And why is all this excitement? Because there are a lot of technological advancements that allow developing very sophisticated, cost-effective AI models. I'm not going to run through all of these things, but some of them are like increased computing power, big data capabilities, improved algorithms, and there are natural language processing, variety of neural networks, convolution type, recurrent neural networks, etc., cloud computing, and of course then there is also development of specialized hardware for some of these applications, and open source software and libraries. So an example of, all of these things have some kind of a general outline like this. How do you, if you want to build an AI model? Some of the data processing is required. You do a simple signal-to-noise analysis, and then, of course, normalization is to bring data from various platforms together, and then you do a data reduction, and then feature extraction, and you develop an AI model for it. Now, in machine learning environment, there is supervised learning, weakly supervised, and unsupervised. So what is what is supervised learning? You have to, if you take an image, you have to tell the machine exactly where the tumor is, if you're going to diagnose the disease. So you have to separate the tumor and then give it to the machine and say this is cancer, so it knows where it is. Weakly supervised means you take the slide or the image and say, hey, there is cancer here. You don't say exactly where it is. You say the slide or the image have cancer, and then let the machine learn where it is. In unsupervised training, you don't say anything. You just feed the data and then let the model decide how to separate the data. So there are a whole bunch of AI models can be derived from decision trees, support vector machines, again, artificial neural networks. Many applications in radiology, pathology, video endoscopy, etc. And here is an example in renal cancer. Here we are trying to identify small renal masses. Some of them are benign on oncocytomas, and then the other ones are aggressive malignancies, such as clear cell renal cell carcinoma. The issue is when you look at the MRIs, the contrast enhancement on the benign versus cancer looks very similar. So even if you are a radiologist, you're looking at it and then go, we can't separate these two. So if you are going to develop an AI model, what you need to do is, this is actually a supervised learning environment in this particular one. You have to identify the lesion on the T2W image, and then mark it, and then separate as in the D, image D here, and then feed it to the artificial neural networks. And here's a convolution neural network, and in this particular model, they used 74 patients, and there were 243 lesions, and use 160 for training and 160 cancer lesions and 32 benign lesions. And as you can see, the sensitivity is fairly high, 94, and the specificity is a little lower, but accuracy and the overall accuracy and the area under the curve are fairly high. But if you put this into practice and compare with radiologists, and you can see that there's a drop in the sensitivity up to like 85%, and the AI is only slightly better. But the overall accuracy, if you take again, the radiologists, the fully trained radiologists actually perform equally pretty close to AI. But that's not necessarily what you want to do. If you look at something like a bladder cancer, you want to actually have your model actually beat the human operators by a substantial margin if you can. But so here we are looking at for white light cystoscopy. Now, this is a very important tool diagnosing bladder cancer, but the problem is, of course, about 30% misdiagnosis rate, and then about 50% incomplete diagnosis rate, compared to the pathology reports. So these things result in high early recurrence and prognosis, a progression of the disease. So they have developed a very good system here, cystoscopy artificial intelligence diagnostic system, CADE, for the bladder cancer diagnosis. They used about 29,000 images from 10,000 plus patients. And what they did was, again, this is a supervised training environment. They had this pre-processing segment where you identify on the videos where are the lesions are, and you actually train an existing this PSP net, and then use that feature extraction process feeding into a neural network environment. And the results are here, and you can see, within the internal data set, it has almost perfect score. And external data sets, there were 4 data sets they used, and the accuracy varied from 97% to 99%. And here is the big issue, big deal here: the sensitivity, average time, and the compared against urologists. For the trainees, their sensitivity is like 51%. They took 45 minutes to classify these cases. For a competent urologist, it is 56% and 38 minutes. For an expert, it is 75% and took 35 minutes. Look at the AI model, 95% accuracy and 12 seconds. So that's what you really wanted to achieve. The savings advantage come from cost savings, come from the time and all those things. And here are the numbers, down here for 468 positive images and 222 negative images. You can see the AI have very high sensitivity and negative predictive values, and AUC is also, out of the scale here. And here are some comparisons, how they have done all those things with the individual radiologists and the trainees. And on this slide, I have identified some other networks, AI technologies that have been used. There's a Google Net, and then there's a CystoNet. They all have very high sensitivities and accuracies. And so let's look in for prostate cancer, which is very near and dear to me and Dr. Crawford and everybody else here. Many applications, from lesion detection on MRIs to lesion classification. So on MRI, you can identify a lesion, and then classification is that clinically significant, is that high grade, low grade, etc. There are many models. However, there's only one I could find that has been FDA approved for tissue classification, Page Prostate by Page AI. And they have 2 software packages, to Page Prostate Detect. They assist in detecting suspicious lesions. And then Page Prostate Grade and Quantify. They provide Gleason score and percentage of the Gleason pattern and etc., the whole thing. Now, if you dig a little deeper into this one, this is the version 1 I could find, and it was trained on a very large data set. In this table 1, you can see almost 24,000 slides on the prostate side, and they also at the same time trained them on basal cell carcinoma for skin, and then also look at breast metastasis in lymph nodes. Of course, they were individually trained and classified. And this is the weekly supervised learning environment. Why? Because in these biopsy slides, the pathologist doesn't have to go and say exactly which pixels, which area is cancer. They basically said, the slide is cancer, this slide is benign, this slide is cancer. So that was fed into the machine. But because it is weekly labeled, it required multiple instance learning. So we had to train more times than the supervised learning environment. And eventually they were fed into a recurrent neural network. And the recurrent neural network provided a heat map, a probability map on each slide where the tumor is, and then if you go further, they might even give you the Gleason classification. And in this table, I have identified 4 separate studies which tested the PAGE prostate AI, and the sensitivity is, here is 74%. Sensitivity increased from 74% to 90% when the pathologists used the PAGE AI. And here the sensitivity was 97% and specificity was 99%. And the advantage here is, according to these limited studies I can find, it enabled the pathologist to request, save time, and then doesn't have to request more special staining to identify cancer, special IHC staining such as MA903, and there is some cost savings. But again, the application have to be, in academic institutions, you have top pathologists, and I don't think it will be a problem for them, but this probably will be more toward the lower level, more practices where the pathology is not their key thing, but something like this will help them to bring their pathological diagnosis to the same expert levels. And finally, I'll give you an example of physical AI. All the examples we discussed so far are virtual AI because on existing data. This is something we have developed, Dr. Crawford and we have developed at our institution, an optical biopsy needle. Now, we actually developed this thing to diagnose prostate cancer using optical spectroscopy. Elastic scattering and fluorescence spectra of the prostate tissue can be used to real-time classification of prostate tissue, and we have done some clinical trials. Again, we have used separate support vector machines, random forest, and classification. As you can see, the sensitivity and specificity, the overall accuracies are fairly high on this one. And here is the performance on the testing data set. As we can see, this is also fairly good results. The area under the curve is 0.87, and then the sensitivity is 86%, etc. So this is a physical AI model. And in summary, AI models are coming in the areas of tumor detection, staging, grading, prediction of survival, recurrence, and etc. And the application will result in significant cost reductions. That is the important thing. But some ethical concerns have to be addressed, privacy and human oversight, because for successful AI implementation, you have to achieve a balance between AI capabilities and the clinician's expertise, because you don't want to totally isolate the doctor, the pathologist. If you can find that balance, I think there's the future. We are going to have a very bright future with this area. Thank you very much.